On behalf of the International Psoriasis Council, I'm Chuck Lynde, a dermatologist in Toronto, Ontario, Canada. I'm a clinical director of the Lynde Institute and a clinical professor at the University of Toronto. I have spent most of my life dealing with psoriasis, and I'm happy to present this talk on anti-psoriasis topicals in the pipeline. I have a number of disclosures, as I've worked with most companies in dermatology over the years, but none of them are specifically targeted to this talk. My objective is really to review new topical anti-psoriatics in the pipeline. Well, all of us that deal with psoriasis realize that there's been a remarkable run over the last 20 years or so. We've come up with a number of new biologics that we can treat quite severe psoriatic patients quite excellently, with it, whether it's a TNF blocker, an IL-17 blocker, or a IL-23 blocker. So certainly for our moderate severe patients that we're able to access these drugs, we have great therapies. An area that over time, however, that's been neglected is the topical market. We've really not had a lot new over many years, and I'm going to talk today about several molecules that I think will come to the market, because remember, most of our patients, in fact, have mild to moderate psoriasis and could be potentially treated topically and don't all have to be on a systemic drug or biologic. I think this remarkable change has really come about because we understand the immunology about psoriasis much better. We've been able to target the IL-17 pathway, the IL-23 pathway, and TNF. But many of our patients, we need to target possibly other pathways that can make our patients with psoriasis that have a little bit over their elbows or knees or a little bit in their scalp better. So I point out, what about our mild to moderate psoriatic patients and topicals? What are our current options? Well, in Canada, we rarely use anthralin anymore. We rarely use TARs. We certainly use a lot of topical steroids. We use calcipotriol and certainly tazarotene and combination therapies with calcipotriol and a steroid and tazarotene and a steroid. And all of these things can be useful for our patients, but we're going to have even better therapies to treat our patients. What are some of the factors to consider when considering a topical? Well, efficacy, obviously, and safety in view of the disease severity, the vehicle it's in. Most of our patients don't like messy, yucky things on their skin, the locations that might be affected, and the symptoms, how much itching they might have. So what makes a good topical for psoriasis? Well, obviously it should have great efficacy. It should work well. It should have good safety. It shouldn't be causing a lot of secondary side effects. Low frequency application if it's possible. Putting it on once a day would be better than twice a day. And it has to be somewhat cosmetically elegant. Non-greasy, low odor, and fast application and drying on the lesions. So our treatment for psoriasis, the goal is to decrease the disease activity and improve the symptoms. And again, in that box I show in the middle, topical treatments include all of the calcipotriol, corticosteroids, the combination products, the tazarotene, and TARs. And phototherapy is sometimes used in conjunction with your topicals. And then obviously we have our systemic therapies for the more moderate to severe psoriasis, where it's not practical to be using just a topical. Well, why do we need another topical therapy? Well, in the 2018 National Psoriasis Foundation survey, only 14% of the cohort were very satisfied or extremely satisfied with their treatment overall. 75% of those said it was due to lack of efficacy. And 54% of those actually on biologicals said they would have stayed on a topical if it was more effective. And all respondents had previous experience with topicals. 87% of them, in fact, were using topicals concurrently, and 21% were on biologicals concurrently. I think we've all seen this. Even though the biologics can often get rid of a great deal of our psoriasis, there's often some left, and this is where a topical is particularly apt. Thank you for listening, and if you have any further questions, please do not hesitate to contact me at derma@lindderma.com. This was a production on behalf of the IPC Council. Thank you.